Thank you and good afternoon. My name is Del Proctor. I have the privilege to introduce today's fourth session and our respective speakers today. We're grateful to be joined by Dr. Jaffe and Amanda Shackle. Dr. Jaffe is an associate professor at anesthesiology at Wake Forest School of Medicine. He has been speaking nationally and internationally for over 10 years now with subspecialty interests in regional anesthesiology, acute pain medicine, and trauma anesthesiology. He served on various committees locally and nationally and was the regional anesthesiology fellowship director at Wake Forest for 6 years. He attended University Medicine and New Jersey School of Osteopathic Medicine. He's published nearly 50 articles, directed numerous quality improvement patient safety projects, and of special note, last year he was the CM Esterline Award winner given by the AOCA, given to an exceptional lecturer at conference. Dr. Jaffe enjoys traveling, the culinary arts, hiking, fishing, and any sport his 3 young children play. But perhaps most impressive in reviewing his CV is he's been mentored to scores of aspiring physicians and anesthesiologists. Dr. Shackle joined the anesthesiology faculty at Vanderbilt Medical Center in 2018 and serves as the rotation director for the main OR rotation. She attended Texas College of Osteopathic Medicine in Fort Worth and actually presented at this year's mid-year and is actually also presenting tomorrow as well on gastric ultrasound. She's obviously an expert in the field. Her academic efforts are focused on teaching medical students, residents, and fellows with an emphasis on regional acute pain and transthoracic ultrasound. She is co-director of an educational effort for POCUS locally at Vanderbilt, and we welcome them both. Dr. Jaffe will begin the session with his lecture on updates in perioperative acute pain strategies. Please join me in welcoming Dr. Jaffe.
All right, well, thank you very much for that kind introduction. I don't like being the center of attention very much, so you could have just said, here's Doug. That would have been fine, but thank you. I really do appreciate it. So I have taken a keen interest in buprenorphine, and so I've found when I've discussed with other people that buprenorphine seems to be a little enigmatic, and going back to why it might be, we'll see in this talk, I'm going to put many of you potentially to sleep because there is pharmacology in here, and I apologize for that in advance. But I have a plethora of dad jokes, so if I see anybody nodding off, I will threaten you with those, okay? So just beware. Okay, so I do have some disclosures that don't compete with this, and nothing is going to be industry related or anything like that. This is all generic medication related, and I'm not going to be promoting any manufacturers' products or anything like that. Okay, so what are we going to talk about? We're going to talk about opioid statistics. Many of you probably have seen some of these before. There's actually some relatively good news, but each side of the coin, happens to exist. We're going to talk about buprenorphine and pharmacology, and this is the part I'm going to try to keep you awake for. And then the fun part is kind of talk about what are we doing, or what are our recommendations, and what have we seen in clinical practice to see how we can apply buprenorphine to our practice that might benefit patients. Unfortunately, it's not going to be flush with literature because it's a very difficult concept to study. So I wanted to point this out. This is from a website that's free. The CDC published this. I believe they update it weekly, but for the large majority of the large data sets, they're not available as frequently updated. So this is going back to 2013, this was published. And you can see here where I hail from in North Carolina. There's, do I have a laser pointer? No. A mouse, maybe? Yeah, okay. So North Carolina's right here, and you can see the highlighted circled areas. This from 2013, and the darkest square I just want to point out for the math is that this is a rate per 100, and you can see on there that there's greater than 112 prescriptions per 100 people, and that's more prescriptions than people in those dark red areas, and it's like that all over the country in 2013. Where the good news is that in 2020, I don't know if the 2021 data is available yet, but for 2020, and the pattern is going in a good direction. You can see there's a lot less of that dark red. It still exists. There's still some difficulties with the prescribing trends, but it has gotten better. So yay for all the organizations and the people who have advocated for different strategies in opioid dispensing. Not to, the discussion today is not necessarily going to reflect the problems associated with the changes in these map colors, and they do exist, but we've seen this happen. Just, this is what it is. So let's talk about buprenorphine. We're going to see more patients who are taking it, so let's talk about it. We're going to see that you will find with increasing frequency people showing up either unannounced, for example, emergency procedures, or having been victims of what I call the traumatic chronic disease of trauma. It's a chronic illness. It really is. You see people over and over again. But in this demographic, people who are about adult age, if you consider 15 and up adults, there's been a significant increase. It's about doubled, right? It's gone from about 2 to a little more than 4 in this time frame. And this study was done for the 10 years of 2009 to 2018. So if you break it down by subclass of age groups, there's a 4-fold increase in the use of buprenorphine in that age category from 35 to 44 years old. So it's going to be more now because of that lighter colored graph that I showed you, that people aren't getting as many prescriptions for opioids that are direct acting. They're going to probably be seen with more frequency these people getting buprenorphine prescriptions. So back to a little bit of the history. Back in the 70s, buprenorphine was introduced to practice, was FDA approved for the indications you can see on the screen. There are off-label uses of it, and I'll mention those since this is a CME activity, but there are off-label uses of it, and one of the things that makes it difficult to adopt is the way that the pharmacies will be allowed to dispense this medication based on some DEA issues. And I don't do any prescribing outside the hospital, so I don't experience that. But what I do experience is the pushback from the people for whom I consult, telling me that they don't have the resources to be able to manage an outpatient prescription, and that makes it extremely difficult to want to offer it to a patient in the hospital and not having it be an option for when they're discharged. So that's like a 2-hour long talk, and we're not going to talk about that as much today. But suffice it to say, the patients do show up either on buprenorphine, or they show up and they say, I'm addicted to heroin. I don't want to continue to be addicted to heroin. My rock bottom is these rib fractures I got because I crashed my car. What can you do to help me? Well, what is it? So it's a partial agonist of the mu receptor. So that means we're going to get the usual stuff that you see: analgesia, constipation, nausea, vomiting, itching, things like that. But the unique thing about it is it is an antagonist at these other 2 receptors that, I don't know about you, but in med school I kind of brushed these aside because they didn't seem important. Well, all of a sudden here they are. There's potentially some efficacy that applying this drug may provide some benefits to the patients who are otherwise not really good candidates for direct-acting opioids. But the problem is, and I think this is one of the issues why it's harder to adopt, is that they don't follow the rules of immediate release opioids. The pharmacology is different. Plasma levels do not generally correlate really with anything. It happens to be so subjective, and the patients tend to behave differently when they're treated with this than what we're used to with mu opioids, and that's the hard part. The plasma concentrations are relatively different for the ways that we prescribe buprenorphine. It's available IV, sublingual, transdermal, transmucosal, so varying degrees of absorption and the pharmacokinetics of it. And, if I need to insert a dad joke, just raise your hand. So the half-life can vary as far as the plasma half-life, but one of the key things to consider is look at the elimination half-life. That's a long time. And so we struggled a lot probably in the mid or early 2010s when it started to be an issue, trying to decide what are we going to do with these patients when they show up for surgery. So it's very difficult to predict this drug and whether or not it influences the patient's response to either the acute pain state, the chronic pain state, or interactions with other analgesics in the opioid family. So very, very challenging. It is very highly bound to the mu receptor. For example, our relatively fat-soluble immediate-release opioid of fentanyl, sufentanil, much less likely to stay bound for the duration that buprenorphine has. All right, but there's some challenges in how it's metabolized, and so that probably has an influence on why there's some varying degrees of unpredictability for how long it lasts. So these complexities really do interfere with how we try to anticipate what is going to happen with the patients who take this if we start at de novo, and even more so, what about the patient who's already taking it when they show up and they have a terrible pain scenario, broken ribs, long bone fractures, whatever you have. So one of the issues is there's really not good data out there to substantiate really firm clinical recommendations or even base your own practice off of. One reason is, and I've said this before, if you've ever heard me talk about anything in pain related, it's a very difficult subject to study because of the subjectivity of pain. And so without something concrete and observable, maybe something like a lab result, or as I joke around, the Star Trek tricorder, that when you ask your pain patient, what's your pain? It's, oh, it's a 10, while they're doing their iPhone, and you say, this thing says it's a 6. We don't have those tools, right? So we have to take what we have and really kind of use either the patient's report, which generally are lay patients, right? They typically don't have education to understand what a paresthesia is and where that regional nerve block might still kind of be working, or how their pain is waxing and waning, and be able to then describe that to us. A lot of it in the literature, the data that we have, is really case reports. People like me who stand up here and talk, or people who write case reports and say, hey, I did this for 4 patients, look what it did for us. It's super helpful. You know, we really do have a little bit more need for scientific data, but again, it's really hard to do. And then these expert consensus. I don't profess to be an expert about this, but there are groups of individuals who are smarter than me that put their heads together and amazingly had come up with a relatively reasonable opinion on how to try to manage these patients. So looking at the pharmacokinetics, we're talking about the bad and the good, right? So we want to know, how much risk am I exposing my patients, and then what am I going to get? What's the bang for my buck? Well, there's a lot of details in pharmacy literature that have some concrete data to suggest that we do have a larger therapeutic window for this. In my experience, this is anecdotal, of course, and I'm not an expert, so this is low level, but this drug is very difficult to hurt somebody. I have not ever administered this drug and seen anybody become apneic if they don't have other substances on board. And apnea really is my biggest concern. You know what, we can treat nausea and vomiting, that's unfortunate. If they really want us to do something about their pain, this is a relatively safe drug compared to really any other drug. Has anybody ever heard of somebody dying from taking 1 too many oxycodone tablets? Has anyone in this room, raise your hand, has anyone in this room ever heard of somebody dying from taking too much buprenorphine? I haven't heard of that. And that's pretty amazing. That should send some chills up and down your spines. But why aren't we using it more? There's probably no ceiling effect relative to the apnea problem, right? There's probably a big deficit in how much analgesia we're willing to give our patients because we're being so conservative with a relatively unknown entity. And that's one of the problems. I don't think we get enough training in medical school for pain alone, let alone the narcotics that we have available to us, because I don't know about any of you. Does anybody in here remember being told about buprenorphine when they were in medical school, pharmacology? I don't. And I did it twice. I did it as a nurse first, and then I took the same course again as a physician, or as a medical student rather, and I never heard it. So it's really just, it's something that's not widely disseminated. It's just easier to write somebody a prescription for oxycodone or Percocet or hydrocodone. And then this other thing that we espouse from buprenorphine is the whole addiction management portion. And this talk is not geared towards that. But just know that there's theory in the pharmacists who do the research that they think that this kappa involvement might be one of the reasons why it does a pretty good job with managing some of the cravings in patients who are addicted to other opioids, and also preventing or maybe ameliorating some of those withdrawal symptoms. Unfortunately, there is conjecture that it can precipitate acute withdrawal as well. And I haven't seen that, but my colleagues have reported that they have done that to patients unknowingly and unwillingly. So in a study that we have from a pharmacology journal, they make this pretty bold statement, and I don't know if we shouldn't listen to it, but here it is. Again, they don't think that there's a ceiling effect. They publish this saying that there probably is full opioid agonist activity with this medication. And I think that we do see this, because I will tell you that in practice, anecdotal again, is that we do have those patients who are described, using heroin, crashed their car, came in, found out they had a vegetation. So not only do they have broken ribs, so they also had a sternotomy for a valve replacement. And those patients are epidural, ketamine, buprenorphine, and that's it. And they do very well. Now that's a lot of stuff. That's, the Tesla of analgesic plans, I guess, if you will. The very, very, I don't have any stock in Tesla. That's a very robust analgesic plan. But the only opioid that they're exposed to is the buprenorphine, and those patients tend not to withdraw immediately after they use their last opioid, which generally is what causes them to have these situations. So their conclusion is, and they gave you the opportunity to read through it, and it was a very dry article, I will admit it. But at the end, the conclusion, when they boiled it down, these numbers kind of mean something. So take a look at this. The ratio that they point out there, if you have a ratio that is 1 in this scenario, that means that it's a 50-50 chance if it's going to make you apneic or it's going to give you pain control, right? If the denominator is smaller, the number is greater than 1, and you should have more analgesia than you do risk of respiratory depression, all right? So I don't know where they got these numbers. They explained it in the article, but honestly, my eyes were getting a little bloody trying to read it. But essentially, they're trying to make the point. Look, here's some numbers about why the therapeutic window is probably much bigger for buprenorphine than fentanyl. All right, we're used to fentanyl. We use it probably out of habit now, right? Many of us probably don't even think. We're just, 50 of fentanyl is supposed to do that. Kind of like tying your shoes. But not many of us worry about that, because a lot of our patients, we've already made apneic before with a paralytic, and we're controlling their respirations. But this is an example of another piece of literature that suggests, hey, look, relative safety, 12, 8, 9, 10, 12 times that of fentanyl. That's a pretty big deal. So if that isn't good enough, here's another article about 5 years later, 2014, and these folks did a pretty good job about talking about analgesic efficacy. Again, very difficult topic to study. Put you to sleep to try to read the article, but let me give you the key points here. Big hitters. All right, so I violated one of my rules of making a PowerPoint slide, and I cheated like on Twitter. You know how you only get 120 characters of Twitter, but if you take a picture of War and Peace, you can put the whole thing on Twitter, right? So I did this. Sorry, I apologize. Too many words on the screen. So let me just show you. All right, so right here, full agonist analgesic effect, right? As the same effect that you see from the opioids that we're used to. And then they went and reminded us down here that in clinical practice, not just in a lab with some rats, they recommend that they think that this drug has full analgesic efficacy. So again, why aren't we using it? Okay, it's safe, it's full agonist. Anybody see any problems here with just the pharmacology, right? It's not, it's just complex because we don't know about it, people don't pay attention to it, or they're afraid of the social ramifications. What do I do to get the patient outside the hospital if we're going to use it? So we have this management problem. So what do you do when these patients come in? All right, well, the patient comes in and they're using it for MAT. Does everybody know what MAT is? Medicated assisted treatment, right? Trying to abstain from the use of opioids that aren't under the supervision of physician. What do you use if they're using it for pain? They come in for surgery. How do you counsel them on that? But what about in the decision tree? Where do you start the decision tree? Do you start with the indication for buprenorphine? Do you start with how intense the surgery is going to be, right? Or do you start with a surgery that may or may not be applicable to a regional technique, something that you could probably make the patient completely insensate in that part of the body, and opioids are kind of immaterial for a while. It's hard, and if you look, dozens of university health systems have published, hey, this is what we do. Mayo Clinic, Cleveland Clinic. I think, I don't even know if we might have tried to publish something on our own website, Wake Forest. But they're all similar, but they're all different. So it was kind of like, you put 10 physicians in a room, you get 11 opinions. So the prior recommendations, if anybody remembers this, stop the buprenorphine altogether. And then just, I will tell you they were suggesting to put them in an ICU, put them on an IV, and wait until they get comfortable, watch them for respiratory depression. Just go ahead and hammer away at your PCA hydromorphone until you're comfortable or you're apneic. Okay, the therapeutic window of that does not seem as wide as buprenorphine. Okay, and then, so we have all this evidence now that suggests maybe that's not the right thing to do, and it's probably true. But what about if we reduce the daily dose, and then if they feel like their buprenorphine is not adding enough analgesia, then maybe we could talk about adding a direct-acting opioid for a short period of time, because there's a lot of evidence in human studies even that if you have a total daily dose, now this is a sublingual buprenorphine preparation dose. If you have a less than 16 milligrams total daily dose, you actually have about 15 to 20% of mu-opioid receptors that are still available to be occupied by direct-acting opioids. So the patient who comes in taking buprenorphine and hydrocodone, well, that's not necessarily an improbable situation. I do see patients who come in and they say, yeah, you know, I can tell when I take my hydrocodone, let's say, I do notice a benefit in the analgesic value. So, okay, well, let's talk about what to do then. So how about we just get some evidence to say, you know what, let's close the book, put the nail in it. Continuing it is probably better. So this group of people did a study and they looked at those who continued it preoperatively into the perioperative period, and then a separate group of people who held it and then didn't continue it afterwards. So I'm going to show you two charts here. This is the group that either continued it or held it preoperatively. And you can see on the right-hand side is discontinued. On the left-hand column, it says the folks who continued it. And for all of the time points that they looked at for opioid usage, it was much more in the people who discontinued it, right? So they were requiring more to achieve a relatively similar amount of analgesia compared to the folks who continued it, all right? How about post-operatively? Okay, well, now we're looking at those who restarted their buprenorphine if they had stopped it immediately after or during the post-operative period, and you can see the same thing. The folks who didn't restart it had higher opioid requirements than the people who continued it. So another body of evidence to say, okay, well, this is going to add value to your practice. This shows that the people who continue it, sounds like they do better. Now, opioid usage, as far as you can throw it, is a surrogate marker for pain, like I mentioned in the beginning. So what does that mean? We don't know. Do they have less incidence of nausea, vomiting? Did those people get out of the hospital sooner? It doesn't look like it. The length of stay was similar. So, but the patient's experience might be better. So there's value in that. Press-Ganey scores might be better. I don't know. But this is what the data is telling us about it. So it's relatively safe. And again, we have a drug that seems to be functional in the analgesic space. So this is hard to read apparently on my screen. It looks a little better on that screen, but essentially this is an example of the recommendations from a society. Those of you who are fortunate enough to hear Dr. Viscusi, he was the past president of ASRA. He was very, very heavily involved in the creation of this. This was published, I think, in 2021, if I remember correctly. And this is a very busy slide. But the biggest thing that they put at the top, I mean, really, other than the title, the largest font in here says, don't routinely stop it. And I subscribe to that, and I think that's a really good idea, because we just saw in the last two slides that stopping it was really not beneficial for the patients. So this is available in the RAPM journal in 2021. If you want to blow it up and make it a little easier to read, you can publish this near your preoperative assessment clinic or what have you. But they did take the time to really put out this information, say, look, we know there's a deficit in the quick reference guide for buprenorphine management. Let's put one together. And there's significant amount of published data that they could use to then add to their clinical experience. And I think this is a pretty good tool. And it is very similar to the ones that Mayo have published or Cleveland Clinic have published in the past. So I see a lot of similarities, and kind of near and dear to my heart, the regional anesthesia recommendation for pain is always appreciated. So, all right, so what about perineural buprenorphine? Because we've talked about systemic buprenorphine. Well, as far as perioperative management, we've started incorporating this in our practice, and there's quite a bit of literature out there. And one of these studies, there was a difference in how long the patients perceived their analgesia. Again, we're talking about subjectivity, so you can take that as far as you'd like. But giving the patients a local anesthetic that included the adjuvant of buprenorphine compared to giving a different set of patients local anesthetic alone and then giving them intramuscular buprenorphine. So they're pretty slick with how they designed it. It was longer in the perineural group. There was, however, a higher relative risk versus the control group, and they didn't really have an explanation for that. You're exposed to an opioid, whether it's in the interstitial tissue versus sub-Q versus IV, why would there be a difference? I'm not sure that is really ironed out and whether or not that holds true in clinical practice. We have been using buprenorphine in our blocks for a while. We haven't seen a big uptick in the patients complaining of nausea and vomiting that we're aware of. And then if you saw the folks who had IM versus perineural, these folks had no difference. So there was a big jump in nausea for patients who were controlled, but didn't seem like there was a difference if you got it IM versus IV. So just to sum up here, I know it's 30 minutes. I could probably talk about buprenorphine for a couple hours, as I mentioned, but it's a unique drug. And with that comes some challenges that are difficult in the busy practice. I mean, this is a lot to digest and go over with the patients. And even our chronic pain colleagues are having a challenge, managing this scenario. We're going to see more patients who are coming to us that have either been exposed to it or are probably not going to be allowed to have immediate release opioids because of criminal histories or behavior problems or addiction issues afterwards. So we're going to see this perioperatively much more. The problem is there is a real risk of patients who don't get to continue using their buprenorphine, even for a short period of time, that they will find themselves seeking alternative opioid management strategies like heroin or street fentanyl or someone else's oxycodone in order to prevent what they deem to be probably one of the most serious consequences of opioid abuse, which is the withdrawal. For some reason, apnea is not high on their list. I'm glad that we are still favoring regional anesthesia techniques because I want to keep working and studying it. And if you do encounter a patient like this, in the negotiation chapter of Dr. Nichols' book, I'm sure there's a mention, I didn't read it, but I'm sure there's a mention of how to try to get the other person to think that your idea was their idea. Well, I think you have to do this with your patients too. You've got to find a way not to convince, which is way harder, but persuade them. And to convince someone that they need to do something, they're probably not going to do it as much. But if you persuade them to think that it's their idea, they're probably more likely to jump on board. And then the same thing when we talk about, hey, look, we're going to reduce the dose. We're not going to take it away. We're just going to lower it in case we need to do something a little different when you're having your surgery. That way we have plan A, plan B, and now that you've done this, we have plan C as well. And I think that would bring comfort to the patients. They might be more willing to participate in that, knowing they're not going to take it away. But you've got to probably have discussions with multiple people. The original opioid prescriber, the patient has to be involved in that decision as well. So that's my really, 30,000 foot view of what is going on in our practice and what I see in opioid management as far as buprenorphine presence in the perioperative analgesic space. It's a challenge because I think some folks are afraid of the drug because they don't know enough about it. And to me, just like ketamine, to be afraid of some bad dreams when you have a drug that really won't make people apneic in the usual clinical doses, we should probably embrace that more. It's probably a safer drug. Same thing with the buprenorphine. It's probably safer. We haven't proven it necessarily. We have a good data, but it really is a significantly larger therapeutic window. And so I think an adoption of that is probably not going to make an untoward burden on the apnea risk, but I think we have some social and prescribing practices to worry about. I think that's one of the challenges, is how do you kind of get the patient out the door and on a new buprenorphine regimen if they don't already have established care with a chronic pain physician who might be familiar with it. Anybody in this room think that it's easy for their patients to get a chronic pain physician to see them a couple days after they're discharged from the hospital for a traumatic event or surgery? That's another problem, right? Access to the specialist. So we have a long way to go, but I think there's maybe some comfort in we've got another opioid that we could use that's full agonist, probably going to be hard to really hurt somebody with it. All right. So thank you very much for your time. I appreciate it. Of course, at the end, happy to ask questions.
Thank you, Dr. Jaffe. Excellent presentation. Appreciate your time and thoughts there. With that, I'd like to welcome Dr. Amanda Shackle.
So now we're going to kind of shift away from Dr. Jaffe's excellent talk on buprenorphine and kind of talk about some other areas where we can kind of add value in terms of reducing opioids. And so I'm going to be talking about some new innovations in fascial plane blocks. I don't have any financial disclosures. So by the end of this session, I'm going to hope to have covered, I'm just going to move these, several gaps in regional anesthesia care. I'm going to describe several new fascial plane techniques and address some of the challenges that we face in translating some of these newer blocks into practice. So here at my own institution, Vanderbilt, way back in 2011, long before I ever arrived there, we did a lot of regional anesthesia. This may, be a similar situation at your own institution. We were heavy on orthopedics. We did, some regional for large abdominal surgeries, thoracic surgeries. And now we contrast that with what we're doing now in 2022, and we have tremendously broadened our scope substantially, now blocking laparoscopic procedures, plastics, even being asked to block patients we would have never considered before, like big hepatectomy cases, and even some of our cardiac cases as well. Some of this is due to the success of our ERAS program, of course, but some of it also reflects some of the new available techniques. And so even if you're not heavy in regional in your own practice, you're going to be increasingly asked to do patients, to block patients that you might not have considered before. So regional anesthesia and analgesia continues to evolve at an accelerated pace. And so we have to think, what's driving this pace of change and that we may even find in our own, when we look at our own institutions. And of course, there are many factors at play here. A lot of it has to do with the opportunity of our high quality ultrasounds that we have now. What we've seen is a development towards targeting smaller nerves located in anatomic planes rather than targeting larger peripheral nerves that we can actually see on ultrasound. And so this kind of fits into our broader category of fascial plane blocks. There's been a flurry of fascial plane blocks that have been described in the literature recently. And obviously with so many, all the osteopathic physicians in this room know, with all the many muscles and bones in the human body, there are endless opportunities here. So there are a number of needs in regional anesthesia, and I have characterized several of them on the left, and we're going to kind of go through some of these one by one. But really, what this reflects is an insufficiency of some of the current techniques. And even just having a small need that might guide discovery of some of these new techniques. So we're going to use the word gap, okay? And I'm using the word gap intentionally here because it leads to a type of analysis, like gap analysis. And you can see, some of those questions here that you can use to perform gap analysis. And what this does is it's incredibly useful in helping you to identify unmet patient care needs and how you can incorporate a new need into your clinical practice. So the first gap we're going to look at here is the analgesic gap. Even with good oral, IV, multimodal analgesia, even adopting buprenorphine, as Dr. Jaffe has suggested, regional anesthesia can help further reduce opioid use. Now, I know there's been several sessions that have addressed opioids during this conference, but I'm just going to hit on a few points here. This is a little bit, several years old, but it's from Dr. Berman and his group, who looked at a pretty large group of surgical patients, 36,000 patients, and he was able to define the rate of new and persistent opioid use after surgery. So it was new in that these patients had not had any opioids in the last 11 months prior to their surgical procedure, except for they were allowed one prescription 30 days leading up to their procedure, and then they could have prescriptions through 2 weeks after discharge. It's considered persistent because they looked at the window of 90 to 180 days after surgery, long after what we would consider acute postoperative pain. So in those patients, they looked at major and minor surgeries, and you can see several of the surgical procedures they considered here. And they had a comparator group who didn't end up having surgery. What they found was quite staggering. Between 4 and 10% of patients ended up with new persistent opioid use. And this didn't change based on major or minor surgery. And so something is happening here around the time of surgery that is increasing these patients' risks. So I'm just going to put up a few numbers just to really drive this point home. So 50 million patients undergo surgery each year, and we are obviously responsible for the care of those patients. 6% end up with a new persistent opioid use. Over 70% are overprescribed opioids after surgery, and 80% of heroin users started by taking prescription drugs. Now these numbers are getting better. Things are moving hopefully in the right direction, but there's a real need for alternatives here, and so this is what is driving our practice. So I wanted to provide a snapshot. It's kind of hard to read. There's lots of different words on the screen here, but this is a snapshot of our ERAS protocol for one of our abdominal surgery cases. And we put all this effort into this protocol to help cut down on the opioids without, sacrificing any analgesic aspects. And we've largely been successful, but depending on the surgery, patient factors, some of our more traditional fascial plane blocks may not be sufficient, or even epidurals may not be a great option. So sometimes we need a different plan, a rescue plan, and so there's a need for good analgesia even in patients who weren't traditionally candidates for some sort of block. And I think this is a main component that's driving some of these block developments. So novel innovation in fascial plane blocks is driven by, in my view, two main goals. One goal to avoid side effects, whether that's blockade of major motor nerves or complications, namely hemodynamically significant autonomic blockade. The other goal, of course, is to provide coverage where some of our older techniques have failed, namely in extended dermatomes or in some of the watershed areas. So in searching for new blocks, of course, as I mentioned, there's the desire to avoid side effects with existing ones. So for ambulatory surgery cases such as an ACL repair, I rarely want to block both the patient's saphenous and sciatic nerves because the foot drop paired with their knee immobilizer makes it very difficult to get them home after surgery. And so to provide more patient-centric care, we started using the IPAC block. So there are multiple approaches to this block, but typically it consists of using a curvilinear probe, looking in the medial aspect of the thigh towards the popliteal fossa, where you visualize the femoral condyles and the popliteal artery and vein, and then slide the probe proximally until you see the posterior femur flatten, and advance the needle medial to lateral between the vessels and the femur. depositing about 10 mLs of local anesthetic and as you withdraw. This blocks those small branches that come off the tibial nerve to innervate the posterior capsule of the knee, providing analgesia without blocking any sort of distal motor function. So we are also asked to do procedures for patients at high risk for hypotension as well. This makes epidurals with the risk of a sympathectomy challenging to use at times. I'm thinking particularly of nephrectomy patients where, for the sake of the other kidney, we want to maintain good perfusion, or esophagectomy cases where we want to avoid large fluid resuscitations, and those patients are chronically malnourished and usually very prone to hypotension. Or I'm thinking about our polytrauma patients where sternal fractures where if we did a high epidural, we will block their cardiac accelerator fibers. So clearly there's a need for procedures that offer more hemodynamic stability. So what you can use for isolated sternal fractures or even sternotomies is the pectointercostal fascial block. You can perform this by scanning peristernally, identifying the pec major, and targeting the plane between the pec major and the intercostal muscle or rib, and open up that plane with local anesthetic, and that will allow flow across multiple rib levels along the sternum, blocking the anterior branches of the intercostal nerves, obviously unilaterally, obviously on that one side, and of course you'll want to repeat that on the other side. And this should provide some analgesia. The transversus thoracis plane block, as you can see here, is similar. It's performed in a similar region, but you're targeting the plane between the intercostal muscle and a deeper muscle, the transversus thoracis muscle. The local then spreads under the ribs, blocking the same nerves, but this block is a little bit more challenging and has a little bit more risk associated with it, as care must be taken to avoid damaging the internal mammary artery, and obviously the pleura, as you can see, is pretty close to the area of injection. So now we have the rector spinae block as another new favorite block. It really is a very relatively simple block to do. It's very similar to, those of you who are used to performing paravertebral blocks, it's similar to that, but instead of entering the paravertebral space, you will inject along the transverse process and peel the rector spinae muscle off the bone. This space is extremely intolerant of fluid, and so that actually allows for nice spread in both directions to a large number of thoracic dermatomes, and even some lateral spread along the chest wall. One cadaver study showed better muscle staining with the ESB block rather than a retrolaminar. And so looking at this coverage area, you might begin to think of lots of different reasons you could use this block. And it also has been shown to be very hemodynamically stable, and that is generally true, as well as it's not, the block's not performed, in the thoracic cavity like the paravertebral, or even in the neuroaxis like the epidural, and so it may be for anticoagulant purposes considered more of a superficial block, although that is still a bit controversial. Though I showed you one study that showed extensive muscle staining, there are studies out there where the cadaver work didn't show quite the staining that we would hope for, but more just kind of muscle staining and not really any dye spread to any of those deeper neural structures that we're targeting. And this really begs the question about, the reliability of this block and really how is this block actually working? And it also should remind us too, and beg the question about how effective are these cadaver studies, in assessing block spread. There are significant differences, obviously between dye and local anesthetic, and of course, from fresh cadavers and even living, breathing humans. So So perhaps we need to look for other, options for assessing spread. So perhaps maybe X-ray or MRI contrast studies might be better at demonstrating dermatomal spread that we are seeing with our erector spinae blocks. Another additional source of confusion with the ESB block is the potential for variation in the layers where you are actually depositing the local anesthetic. If you're too shallow in your injection, you're going to inject in the erector spinae muscle itself. If you're too deep, then you're going to end up getting a paravertebral. And so how you reliably get the spread in the right place is a real challenge, And with that, I'm going to move on to another very fashionable hemodynamically stable block, the quadratus lumborum. This also can cover a large amount of abdominal dermatomes and, has potentially replaced the TAP block for some of our surgeries. And one can even make the argument that it can even replace even epidurals for certain procedures as well. There have been several issues with this block. There are several different approaches to it, and there's a complete lack of consistency in terminology. As you can see here on the screen, you have the, Q1 here, Q2 here, Q3 here, and there's even a deep block, even a Q4. And then they've also been named, same by their position. And so we have lateral, posterior, and anterior. So can be very confusing in, trying to describe your approach. And with that, there are many different ways to approach this block, with everybody kind of doing it a little bit differently. You can have the probe oriented in the transverse or parasagittal plane. You can have the needle come from medial or lateral or cephalad or caudad, with the patient either positioned lateral decubitus, prone, with a bump, sitting. There's a lot of variability here, and so that has made it very difficult to compare different approaches across studies. And I think this has significantly impacted its broad acceptance. So now we're going to kind of go back to our gaps and look at some of the areas, of coverage. There are just some areas of the body that are just hard to cover. And areas with a lot of dermatomes involved are hard to cover with one block. I mean, it certainly would be nice that we could just put one block and cover a wide range of areas, but sometimes this isn't possible. Even with epidurals, it can be difficult to cover an entire laparotomy incision, especially without causing significant hypotension. So the aforementioned QL and ESB blocks may be able to fit this need, that we have here. And so now we're going to kind of look at watershed anatomic areas, and so as a reminder, a joint is innervated by all nerves it passes. We remember this from medical school. And so if we think about the hip joint, there are a lot of nerves that pass it, and therefore there are a lot of nerves that contribute to pain. And so we have to consider all these different nerves when we're thinking about planning a block for these patients. And so obviously there are several different block techniques that you can do to hope for, coverage. And obviously with there being multiple nerves you need to cover, multiple blocks may be needed to cover all of those nerves. And so we're going to look at a couple here. We're going to look first, obviously there's the classic fascial block, which I don't have pictured here. And that has been touted by our orthopedic colleagues as likely to benefit patients with hip fractures, and that is generally true. But I want to offer the suprainguinal fascial block, or SIFI, which is a more proximal abdominal approach to target the femoral and the lateral femoral cutaneous nerves. Its proximal location pushes those nerves closer together and theoretically improves coverage. So in order to perform this block, you place the probe just medial to the ASIs, look inward towards the pelvic wall, and visualize the iliacus muscle You'll see over top will be the internal oblique and the transversus abdominis muscle. And then have your needle travel in plane from medial to lateral to tuck in and dissect that plane between the iliacus and the TA. And of course, we have a nice cadaver dye study here showing great spread. Another block you can consider to do for these patients, and this is a newer one, is the pain block or paracapsular nerve group block. This was developed out of the thought to cover more proximal femoral branches as well as try to target that accessory femoral nerve in order to help optimize more coverage of hip fracture pain. This block is performed by placing the probe transversely over the AIIS and then rotating 45 degrees to align with the pubic ramus, and then the needle is advanced from lateral to medial, targeting the plane between the iliopsoas tendon, which I'm going to try to outline here, and the pelvic brim. And so you can see the local anesthetic kind of opening up that space nicely there. And so with that, we'll now move on to some of our other types of gaps that we have here. Some of our existing techniques are susceptible to anatomic variation and certainly in ways we don't fully appreciate. Hubbard described some interpatient variability in how the nerves travel through the abdominal wall, with less variation being noted more lateral on the anterior wall body. And so he showed a narrow and variable distribution of anesthesia with tap blocks. So these facts suggest that maybe there's a potential advantage for more proximal approaches, such as the QL block that I mentioned earlier, and you can pick your location of choice there. Often the need for these blocks is driven by contraindications to current blocks. These contraindications seem to mostly come about due to anticoagulation concerns, and with an increasing frequency of anticoagulation use in our community, we are often prevented from doing spinals and epidurals in patients that we otherwise would do so, and so it's handy to have more superficial techniques at our disposal to help these patients. Another driver of innovation is dissatisfaction with block duration. Now, I'm not going to go into all these different medications here, but and this certainly hasn't necessarily driven, procedural innovation as much as it has, different drug formulations, or additives, including buprenorphine, as Dr. Jaffe has mentioned earlier. And there's been certainly plenty of work on the last decade of additives and their ability to extend duration. And of course, catheters always, reliably extend duration, but take more time to place, come with technical and organizational challenges. Lipid formulations were introduced at a high price point as a method to maybe possibly extend blocks, but studies are mixed and not well controlled, and I'm not really going to dive much further into that today. So, we've looked at a couple of blocks here today, and so when we're talking about translating these blocks into clinical practice, there needs to be careful planning, complex decision making, and you must kind of ask yourself several questions. Which blocks are you going to adapt? What blocks, at what point are you going to perform these blocks? And what medications are you going to administer, and who's going to do the blocks, and can all your providers in your group or your practice perform the blocks? And if they can't, who's going to train them, or how are you going to obtain the necessary training to implement some of these blocks into your practice? And so, as we introduce new blocks, it is going to kind of change some of the landscape at your own institution once you kind of figure out how to overcome some of these challenges. And it may change some of the threshold to do other types of blocks, or maybe offer no blocks at all. And so kind of going back to what I introduced at the beginning, there's been a trajectory in my own institution. Maybe you have noticed this at yours as well, as we are moving towards doing more blocks and kind of changing the combination of blocks, from having more different complex options as more blocks are becoming available. So I just want to leave you here with a few last points. We've looked at some of the current gaps that exist in regional anesthesia care and how they are driving the advancements of new techniques, especially with regards to some of the fascial plane blocks that I mentioned here today. Innovation has been, obviously driven by the need to reduce side effects, especially motor blockade and hemodynamic instability, and then obviously provide coverage where older blocks have failed. And while there are numerous challenges in trying to translate some of these newer techniques that you may read about, in various journals and papers, into your actual day-to-day practice, and even to get them adopted by your group as a whole, I truly believe that our steadfast commitment to our patients will be our strongest driver yet. Thank you.
Thank you for that excellent presentation, Dr. Shackle. I'll open it up for our panel discussion. I can invite our speakers to sit at our AOCA's version of Between Two Ferns here in the fancy chairs. And it looks like we have a couple questions on the floor.
Thank you. So I asked this question the other day, or it's something about opioid sparing and opioid avoidance techniques. And I know that these were very specific talks, but that seems to be at the root of enhanced recovery, really, right, is finding a way to do all of these things without opioids or without additional opioids. And I'd just like to hear kind of your thoughts on patient involvement in that. So I've gotten into discussions with other people and had a lot of secondary commentary from patients who were very upset or had loved ones who were very upset, didn't feel like pain was adequately treated, and really didn't have great discussions about these approaches that we're doing. And so Dr. Shackle really talked a lot about this, our broad range of things we can do, and then how much do you think we're involving the patient in those decisions, and how much should they be involved in specific opioid avoidance techniques and things like that? Just like to hear your thoughts on that.
Sure. So we almost never in the room with the surgeon when the surgeon talks to the patient, convinces / persuades the individual to agree to a surgical procedure. One of the worst things that I can get is a compliment and say, oh, we have a great anesthesia team, you're not going to have any pain after surgery. I think it comes down to expectation management, and to your question specifically, that is an impossible task. This country has some unfounded history of expecting nothing negative to happen. Does anybody in here remember participation trophies? Yeah, right? There's some people in here who know that. Maybe some people won't admit it, but where did that translate from the person who won gets the trophy, right? The intolerance of anything negative, I think, is unimaginable. If anybody here has had the privilege to go and see what other countries do with their analgesic practice, perhaps if you haven't had the chance, go to Africa. The same surgeries that we're doing here, the anatomy is the same, the neurology is the same. They're using almost no opioids. It can be done. The human organism can survive that. What I think doesn't get a good job is the longer portion of that discussion with the surgeon and the patient where they have to talk about, look, I need to cut the tumor out. No problem, get it. What about pain control? You should expect to have pain. I don't know if that routinely comes out in the surgical discussion, and if it does, it's probably a small portion of the time spent. And not to belittle our surgical colleagues, without them, we'd have a hard time making a living, right? But I think they may not focus on that, and I think we have an expectation problem that is very difficult to manage. So earlier on, setting expectations. As far as patient engagement, you want to take that?
Yeah, I think. Thank you. Sorry. I think that's an excellent, point by Dr. Henson. Thank you for the question. we certainly could do a better job, all of us. It's just hard. By the time we're meeting patients, it's a difficult conversation to have, as we're trying to build trust with these patients right before we're supposed to wheel them back to the operating room. So I agree with Dr. Jaffe. These conversations probably need to start in the surgery office, especially if these are planned surgical cases. We have maybe a few surgeons at our institution that have started these conversations. We have one particular spine surgeon that I can think of who is setting the expectation that his patients are going to get minimal opioids. Now, in practice, we're still kind of ironing out some kinks here. But he is at least having those conversations, and so I definitely applaud him for at least trying to set expectations with certain patients that he's going to take to the OR, that they're going to get minimal opioids postoperatively, and that we're going to give all of our multimodal analgesic options that we have at our disposal to help control their pain. So, those conversations need to happen before they enter pre-op, and certainly, we need to play a larger role in that. It's just difficult when we're, doing cases and we're seeing these patients, in pre-op just moments before we reel them back. So that, that is a challenging time to have these conversations, but I definitely think that we could, try to partner more with our surgical colleagues about setting expectations early. And doing a better job too about explaining options. Lots of patients, are kind of confused about certain blocks or certain techniques that we're going to do, especially, and you would think with how many, knee replacements and hip replacements that are done in this country, that it would be more widely talked about, spinal as an anesthetic option for these patients. And sometimes I find myself having to really kind of explain these different options, and we need to kind of do a better job of that. And so I think that's an area where we can really partner with everyone involved to really try to offer more patient education in this front. Thank you so much for the question.
Yeah, I think that's a great question. Just to add to what you're saying there, we heard a previous speaker today talk about potential complication in ambulatory surgery centers and how to prevent that by optimizing those patients. And I think those of us that are employed with institutions that have pre-anesthesia consultation clinics, it's very easy to distribute literature from the anesthesia team at that optimization stage so that we're not always depending on our surgical colleagues. Dr. Hargrave.
Well, Amanda and Doug, thank you very much for two very excellent lectures. Just a quick question that I had. We do a fair number of fascial plane blocks for our cardiac patients, but erector spinae plane blocks, at this point, we're mostly using those for our thoracic patients. And there's a little bit of debate among my colleagues as to if catheters are utilized, which we do on some of our patients. Is a continuous dosing better, or what about the role of intermittent bolusing in these fascial plane blocks? And with the concept, and I think with the debate that's out there, is that a tight space, you're trying to have some distribution, both caudal and cephalad, and with that in mind, are we better giving one large high-pressure administration versus a slow trickle over several hours? So I'd appreciate any insight you might have into that.
That's an excellent question. There's two parts to that question. The first part of the question, of course, is about using ESBs for cardiac patients. Mostly, for your sternotomy, it's not a good option. Most of us feel that ESB blocks don't cover centrally well enough, so that's not a good option. You might want to consider one of the other two options that I presented on, either the PIF or the pectorinocostal, or the TTP or transversus thoracis block. So those for median sternotomy cardiac cases. Now we do mini mitral cases, which are actually performed. This is a cardiac case where they're doing a mini mitral valve replacement, or sometimes they do tricuspid valve replacement. But instead of using a sternotomy, they're using usually a right-sided thoracotomy approach. And for those patients, we have been doing ESB blocks for. We started, now this is to answer your second question, we started by using catheters when I started working at Vanderbilt, and we kind of got a lot of mixed results, especially after that initial bolus of local anesthetic that we provided when we placed the catheter wore off. We didn't really find that patients really benefited too much from a pain perspective. They were still taking quite a bit of opioids. And then we were trying to manage these catheters. And we found that we to your point about it being a really tight space, we weren't convinced that our pumps, the pumps that we use to deliver the medication, can provide enough force to drive that medication to get the dermal tonal spread that we get with our single injection when we place it. And so we have now moved to doing single injections, and then we offer a repeat single injection post-op day 1. And I think rarely I come back post-op day 2. So instead of going through all the hassle of trying to place the catheter and basically them really not working after the initial bolus has worn off, we now just offer a repeat block. And we try to add several additives, to make them last as long as we can. Decadron, and some of my colleagues are putting buprenorphine in these blocks as well, just to kind of squeeze out just a little bit more duration. And we found this to be a much better practice, and from a labor standpoint, hasn't really proven to be much more difficult or timely.
I think there's a value behind the volume in the fascial plane blocks. It's a different animal than what we're used to when we have the catheter directly at a targeted nerve itself. The non-compliant spaces, we don't know what the compliance of even the epidural space is. I mean, we're really questioning that too, and I think the same concept exists. For a lot of OB colleagues, if you ask, there's probably 60-40, maybe even 50-50. Some places are doing infusions and some places are doing programmed intermittent bolus. I think it comes down to volume, to be honest. I think it's the volume and mass of drug that's going to give you the biggest bang for your buck. There also may be a placebo effect. You're changing something, or you're giving the patient something to do that might buy you some analgesia that's non-pharmacologic, right? We have done the same thing. We've looked at intermittent bolusing for a lot of our blocks, and there's probably a pressure issue as well, as you mentioned, but I think the volume is probably key, and we're starting to swing the pendulum back to larger volumes. If anyone in here remembers original suggestions for an interscaling block approached maybe 50 or 60 mLs in the original days. Anybody remember that? I have a lot of gray hair, but I don't practice I didn't practice at that time. But I remember reading those articles, and now the pendulum has swung all the way the other way. The space is so tight, 5 to 10 mLs is going to get you the same block as 20 to 25 in general. So I think we're going back the other way now and saying, well, now we're not targeting a nerve, we're targeting a potential space. And remember, there's 3 planes, right? It's not a 2-dimensional space, it's actually 3-dimensional space. So there may be the anterior posterior space you have to fill, and then you have the caudate, cephalad, and the medial lateral directions. So we've incorporated an increase in the volume, and we are concerned as far as toxicity goes. No one knows the uptake from those fascial planes either, and I think that's very enigmatic as well. To explain the offset of a tap block when there's not a whole lot of blood vessels that necessarily run through there, is it really the uptake, or is there something else? I don't think we know. So we're kind of leaning more on the volume than we are on the intermittent bolusing to use that. So we still have a fairly substantial hourly rate that gets infused over time. One thing I'd like to offer is maybe evidence for that. When we do a tap block, we typically target the plane between the transversus abdominis and the internal oblique. Most people probably read or heard that before. Our transplant surgeons are putting in multi-orifice catheters for transplants, for kidney transplants, and many of you are familiar that the incision's unilateral. It doesn't typically cross the midline. So that's a little bit of a different animal than a midline laparotomy. Well, they're placing the catheter between the only two layers that they can see because they obliterate the transversus in those patients when they do the peritoneal dissection. So there's no tap plane for them. So they're putting it between the external oblique and the internal oblique. And I haven't seen any data, but they continuously report to me that their patients are using less opioid. Now, are they using less opioid because they're restricted? You know, the easiest way to get somebody off opioids is usually to take them away. That may not necessarily be true with the advent of, street fentanyl, but they report that it's getting benefit, and there may be some value to the volume over time that these patients are getting with that infusion. And they're using an elastomeric pump that does not have a bolus function as well. So we're still leaning on the volume for kind of the answer to that. Long run for a short slide there, sorry about that.
Dr. Jaffe, you had mentioned, I'll just poll the audience here, those of our colleagues out there that are placing epidurals in OB or beyond, continuous versus PIEB, continuous, programmed intermittent?
Yeah, 60-40.
Yeah, pretty close.
I really appreciate you commenting that we need to set the expectations better for these patients, because we're working so hard also to stay away from narcotics. And then I'm working in the recovery room, and why is this lady still laying here for 3 hours and she hasn't blinked? And she's had Precedex and lidocaine and gabapentin up front and all of these ketamine and some midazolam and half propofol infusion and a half mac, and she's there for hours, right? Because it's just so much. We in the studies, we pick out a little thing here and compare it to things, but then you see people in clinical practice throw 5, 6 things other than the opioid at the patient. And I'd rather have my fascial plane block and 50 mics of fentanyl, and they wake up and they're gone, right? So I think we really have to work hard on that. The other question I have is, do you have either of you seen any difference between the genicular blocks versus the IPAC block, or putting them together? I had some orthopedic surgeons not be really impressed with the IPAC block, and I don't know whether some of my colleagues weren't getting it in the right place, and they've asked us to be doing the genicular, obviously without the lateral lower one, but any comments on that?
So with obviously with the IPAC, you're targeting those genicular nerves, so it's the same, your target's the same, but it's just where you're getting them. I'm not super familiar with actually doing the targeting the actual nerve itself. Those nerves are really small and hard to see, in kind of learning more about IPAC blocks, I didn't know this initially, but there are like 3 different approaches to it, kind of like the QL, where, we haven't fully defined exactly like where we're performing this block, and so there may be some, provider variation on exactly where they're putting the probe on the medial thigh. And the way I described it was actually kind of, I forget how they labeled it, but it was actually the IPAC kind of outside of the femoral condyles, and because that's what I routinely perform myself. But there are descriptions of IPAC where you are actually looking more at the femoral condyles themselves, and so maybe, I haven't probably, utilized this enough to really tell a difference, but there may be some provider differences on where they're actually blocking. Yeah, on the height, on the thigh, would be my guess, but.
We have feedback from our surgeons when we changed our practice and started incorporating IPAC that they thought the patients were doing a little bit better. We didn't tell the surgeons that we were changing anything. So we had some good feedback initially. As far as metrics to determine whether or not that has provided a significant difference, I think it's hard to say just based on a few things. One is the variation in the provider's technique, right? Some people might do it intercondylar. And in my opinion, I think that's too far distal. I think you might miss some of the trajectory of those nerves that are already traveling to the capsule. So I err on the side of a little bit more proximal. The other thing that we do, belt and suspenders, is we put out opioid in our block. We do use buprenorphine, and that's an off-label use. So we do 2 blocks. We do the adductor canal and the IPAC block. So we take 1 vial of buprenorphine, and just for convenience, we split it up and put 150 in the adductor canal. And it's 300 mics. 300 mics divided by 2, 150 in the adductor canal, 150 in the IPAC solution. Yeah. So the other thing about buprenorphine is we do know that it's lipophilic, and we do know that it can be uptaken from the skin. So if you bypass the skin and inject it interfascially or interstitially, however you want to define that space around the peripheral nerve or where you're injecting it, there's going to be some systemic uptake. And we also don't know if all of a sudden we're incorporating 300 mics of buprenorphine into our analgesic strategy somewhere, right? It gets into the patient. Is that by itself the analgesic benefit, or does it really affect the nerve block that we do? Our patients are not sophisticated enough to be able to tell a difference, and I don't know how to study that. So we aren't seeing any problems with it, and so we're aware of the therapeutic window of 150, 300 mics total of buprenorphine. Even in the opioid tolerant patient, we haven't seen anybody withdraw from that dose. So we subscribe to that.
Are your knee surgeons putting any local anesthetic?
No, they've stopped because we use 30 to 40 mLs of local, so they're really conservative with that. So they've stopped doing that. The other thing too is that it took us a while to convince them, but the time that they spend doing that intraoperative injection of the posterior capsule was probably not as beneficial. So they let us kind of persuade them that the IPAC is a little bit more efficient for them. We are fortunate we have a pre-op block area, so we get to do that preoperatively. What was the other part of your comment?
Just about the multimodal.
Oh yeah, yeah,
And then I've got these
right.
patients in recovery that are there for
Yeah,
hours where I
Yeah.
would have given them a block of 50
Right.
mics of fentanyl and they would have been awake and gone and eating lunch and
Yeah.
felt great.
extremism I think is hard to manage, right? Swinging from one pendulum, at the apex all the way to the other. I don't necessarily subscribe to opioid avoidance because opioids are great drugs when they're used properly. They have a really good indication, and if they're used judiciously, they have reasonable clinical benefit, right? But to back off the amount that was used before, I think is totally reasonable because we've seen how that affects outcomes. The extremists who say, you can get through a surgery without any opioids, that's totally true. I mean, I can put somebody on nitroprusside and esmolol, and you won't see any hemodynamic fluctuations in those patients, and they'll have surgery. They'll have big surgery, small surgery, whatever. What do you do when they wake up? And you're right. That's exactly the problem. If they have unactivated mu-opioid receptors and haven't had any of the other non-opioid stuff, I think it's going to be a challenge to manage it. I think somewhere in the middle, and I don't know where in the middle that is, I work a lot at night, and I do see that big boluses of Precedex, dexmedetomidine, and even midazolam preoperatively, we will have those patients, even not taking gabapentin, which we've abandoned the gabapentin pretty much altogether. It's all, yeah. Yeah. Right. Yeah. Yep. I agree. Everything in moderation, including moderation, right? As was once said. I think there's somewhere in the middle that's probably going to be optimal, but when you're studying pain, we're not going to find it until the technology's better. Yeah.
I just wanted to piggyback on some of your comments, which absolutely I agree. I think you kind of hit on an age. I think, and frailty is certainly a factor. And so your point basically highlights we can't broadly apply any of these things to just every patient, right? Like that's why we're here. We tailor our anesthetic plans. We should tailor our medications specifically to each patient based on their comorbidities, their age, their other risk factors. And so you're right, we can't just broadly give patients who present for a knee replacement 800 milligrams of gabapentin and expect everyone to wake up in the recovery room. I've certainly been, a witness to this. I cover our recovery room pretty frequently. It's a 40-plus bed recovery room, and oftentimes I have patients that stay there for hours and hours because they got 200 milligrams of ketamine and Precedex and gabapentin and lidocaine drips and all these things. And sure, they have no pain, which is great, but they do take up some of our resources in our recovery room. And so we do need to tailor, all of these things that we're looking at individually, and I, like Dr. Jaffe, don't see opioids as the enemy, but we certainly need to use them, more judiciously and more, evidence-based.
Yeah, and see some flexibility in the ARAS programs, right? You set up an ARAS protocol, and people follow it, boom, 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 and everybody gets everything on the list, and it isn't always quite right for everybody.
I've got a bit of a combo question for our presenters here. I work at a 500-bed hospital on the east side of Cleveland. The president of the hospital is an orthopedic surgeon. So as you might guess, we have a lot of orthopedic surgeons that perform surgeries, which is great on golf outing days because it really decompresses the OR schedule, but not so much for our orthopedic traumas. So we get a lot of hip fractures. So I guess my question for Dr. Shackle is, you described several options. If that's my mom that comes in, what would you do? And then if you would add anything, if you wouldn't comment on type of block, local anesthetic dose, and any additives. And then if Dr. Jaffe was performing the blocks, we know you're adding buprenorphine. Would you consider that just to increase the efficacy of the block, or would you get a prolongation as well?
So this is a great question because this is actually a service line that I cover at Vanderbilt. We each have our own ERAS service line that we all kind of look after, and we partner with the surgeons and nursing and PT, and this happens to be my service line. So that's a great question. So I did obviously present two different, blocks to help with hip fracture pain. I would say, they have their advantages and disadvantages. Certainly, the regular old-fashioned AOCA block is the one that's most widely known, most widely accepted, and so I think that can be appropriate depending on where the fracture actually is. Sure. I think that can be an appropriate block. Sometimes that's an easier block to perform, and so on our protocol, we offer choice, for our providers. There's choice in which block you'd like to provide. We do actually have a standard protocol where our hip fracture patients should be offered a block within 6 hours of presenting to the emergency department. So we do have that there. And because, some of these blocks are newer, and which is what I was trying to illustrate with my presentation today, not all of them are as widely adopted as others. So there is some choice. In your block technique. Now, if I'm personally seeing the patient, and everyone's going to have their own comfort level, with certain of these newer techniques. And so if I'm personally seeing the patient, I try to pay attention to where the break is, what nerves specifically am I trying to target. If you have more distal femur fractures, a fascial AOCA can typically do the job. If it's more distal on the hip, targeting the lateral femoral cutaneous nerve and the femoral nerve will be sufficient. If you were talking more capsular area, that's where those previous techniques are. That's where I was illustrating. There's a lack there. They're not covering those. It's a watershed area. We're not getting obturator. We're not getting accessory obturator. We're not getting some of those proximal femoral branches that are branching off long before it goes under the inguinal ligament. So you're going to miss those. And so that's where I was trying to illustrate that PANG and superficial inguinal, or the SIFI, have really tried to kind of help with that. PANG we use kind of sparingly. I did one recently. It was more for capsular pain. It worked really well for that. And then the SIFI and the traditional fascial are probably more widely performed. Sometimes we put Decadron. We have a few people who use buprenorphine, although I'm really trying to get more people excited about buprenorphine. And so that's typically what we would do for that.
Thank you.
As far as the utility of buprenorphine, the indication, it might be originally we thought it was going to prolong the duration of analgesia. However, that could be defined. As I mentioned, it's a little nebulous. We then started to ask, as I mentioned, is this a systemic analgesic strategy? Is this something that, like when we mix an opioid and a local anesthetic in the CSF, do they potentiate one another? I don't think we have sophisticated technology or patients to be able to tell the difference. So I think in light of existing clinical equipoise, whether one is better than the other or one strategy seems to be the reason that it's working versus the other, in the absence of significant risk, and I think it's pretty low, as I mentioned, I think it's reasonable to continue using it. It is off-label, of course, but it's probably very difficult to espouse a nerve injury from adding the buprenorphine to it, in my estimation. The likelihood that it's going to provide some benefit is high, and the risk profile is probably pretty low. So,
Thank you. Any other questions or comments from the audience? All right, seeing none, I would like to thank our two speakers, Dr. Jaffe and Dr. Shackle, for your time, your expertise, and excellent presentations. Thank you.